This chapter is going to cover feeding and eating disorders. So I'm not really going into the elimination disorders on this one. So we're going to mainly look at anorexia, bulimia, and binge eating disorders. Looking at the clinical picture for each of these, anorexics, or people who have anorexia, lots of times they refuse to eat. They want to maintain a small, this certain weight. And they have a lot of fears of, gaining weight. When we think of anorexia, it's the loss of appetite, and usually this is not what's happening. What they're doing themselves is restricting their food intake, and so they just don't want anything to eat. They have this fear of gaining weight. Their body image when they look in the mirror is much different than what we actually see. They'll restrict their calories, and again, if they feel like they ate too much, they will, sometimes make themselves purge. But mainly it's the restriction of the calories, making sure that they don't eat anything to gain weight, and they will also do excessive exercise to make sure that they're not gaining weight. The bulimia is usually episodes where they have this binge eating, and then they have this uncontrollable urge to just eat, and then they go and they either purge, they take laxatives, diuretics, and excessive exercise to make sure that they do not gain any weight. And lots of times it's hard to tell because many times they have a normal-looking body, weight. They're not skin and bone like the patient with anorexia. So again, though, they still may have some type of disorder where they just feel like they, have no control over something, and they're trying to figure out about their, their body image and their self-image more so than how they physically look. But look at their self-image, but sometimes they control it by using their body to help compensate. When you have the binge eating, these individuals have these huge episodes where they just cannot get enough to eat, and then they feel very guilty about it afterwards, and they're embarrassed about it, and they just feel disgusting afterwards, and they don't understand why they did it at the time. But they'll have these repeated binging episodes, and sometimes it's hard to tell if this is from a binge eating episode or if it's someone who has a poor diet. Here we're going to look at the etiology of these eating disorders. They have found that there is a genetic link that's quite strong for eating disorders. There's also, through genetics, individuals can have the vulnerability to have a poor impulse control and affect. Or they say it could be also due to some type of underlying neurotransmitter that's not functioning properly. However, they have not been able to find a single gene that they can identify and say, yes, if you have this gene, you will end up with the eating disorder. Neurobiologically, they're saying there could be an alteration in the serotonin function that contributes to this dysregulation in appetite, moods, and impulse. With the neurological or neurobiological factors, again, as I said, there's alteration in the function of serotonin in the brain, and this can contribute to the their irregular appetite, mood, and impulse control that people have with eating disorders. There's a nice little paragraph there talking about tryptophan and how they is seeing how that is also regulated, because again, tryptophan is only available through the diet, and so when you have a normal diet, this is going to boost the serotonin in the brain and regulates their moods, and of course there will be drops in this serotonin when they start to have less calories and become malnourished. As far as psychological factors, A lot of times in the past and back in the 70s and early 80s, they believed that it was a defense mechanisms where people were feeling overwhelmed. They felt powerless and ineffective. Maybe there was a lot of pressure put on them by a parent or just some society. And now they're seeing that there's more cognitive behavioral theorists that are saying that lots of times this is some type of learned behavior, and that they're getting the positive reinforcement by someone telling them, oh, wow, you look great, you're really getting skinny, and then they keep wanting to do it more and more, and it starts to reinforce them to keep wanting to and striving to lose that weight. So they really haven't found a lot of research that determines any definitive family characteristics that are specific to the eating disorders. When you look at environmental factors, a lot of people have studied that culture may influence how we see ourselves, our self-concept, and our satisfaction with our body size. And, of course, in the Western culture, they believe everyone who is beautiful has to be thin and tall. They're now showing research that has not proven any kind of direct link between social ideals that are portrayed by the media and the development of the eating disorder. They are saying that peer behaviors and attitudes may actually contribute to the body dissatisfaction, and that's usually what actually will start to trigger this, and lots of times it gets out of control. When we're looking at the assessment part of the nursing process when it comes to anorexia, on your assessment, you want to ask, you don't want to ask them, the patient, if they feel fat. Because this is going to start to make them focus in on the distortion of their body image. So we want to focus on their eating patterns, such as, what do you eat in a normal day? Those are some good questions. Doing a good blood work. Also in our assessment, we want to also, look for signs of malnutrition. You also want to think about, some of the conditions and things that you're going to see with your patients when you look at some of the characteristics. Now, there are cases where they do have to be hospitalized, and if you look at box 18.2 in your textbook, it actually tells you some of the conditions that warrant hospitalization. We also want to make sure there's no other medical issues that have arisen from this eating disorder, and we want to think about support groups, and we need to think about teaching, and are they ready for help for these conditions. If they're not compliant, it's not going to help. So there are medical complications that do arise with these, and so we want to make sure that we're protecting our patient, looking out for their best interest. If someone has the type of binge purge anorexia, they may actually show those severe electrolyte imbalances, because as they purge, they're losing more and more of their nutrients that supplies their electrolytes. The patients who have the restricting type of anorexia, you'll see them as being severely underweight, and you won't see this till they actually take their clothes off. And then they may have some facets of like a newborn called lanugo, which is the little fine downy hairs on their face and their back. Their skin a lot of times are mottled. They're very cool to the extremities because they don't have any subcutaneous fat. They'll have low blood pressure, low pulse, and their temperature will actually be low. They'll actually be malnourished and dehydrated. So they do have possible signs and symptoms of anorexia nervosa in your textbook, and there's a table, 18.1, that actually goes into a few other things that you'll see and why they're showing these symptoms. Main thing we want to know about is their eating habits and their history and the perception of their problem. And then also, what is the value of their body shape and weight to them. Just trying to get an idea what's going on. With the nursing diagnosis, there's several ones, and of course the one that pops out should be, imbalanced nutrition, less than body requirements. Also to their cardiac issues, so decreased cardiac output, risk for injury, um, risk for imbalanced fluid volume, and so forth, as far as your diagnoses. And then you have your psychological diagnosis, such as disturbed body image, ineffective coping, chronic low self-esteem, and powerlessness. For our outcomes, the body image disturbances are considered improved or resolved when the patient is consistently satisfied with his or her own appearance and body function. And again, this is some subjective information. In the planning, when a patient has anorexia and they experience that extreme electrolyte imbalance or weighs less than 75% of their ideal body weight, our most important thing is to get them medically stabilized. One of the things that they do is called refeeding. So when they start eating, we need to look at something that can actually be a detriment to them, and it's known as the refeeding syndrome. This happens when there is a too rapid of a weight gain that can actually overwhelm the heart, and this can actually lead to a cardiovascular collapse of the patient. Once we do have the patient medically stable, we do want to address issues of that underlying disorder. So with this refeeding, one thing you want to think about, a weight gain of more than 2 to 5 pounds a week can actually overwhelm the heart's capacity to pump, and that can lead to that cardiac failure. So you think 2 to 5 pounds a week, that's not a whole lot, especially around the, down towards the lower end of the scale, such as the 2 pounds, but it can be a detriment to their body and to the heart. Let's go on to the next slide. I think this slide is interesting because you may have someone who looks like a 1, but when they look in the mirror, they see themselves as a 9. So they do have that distorted body image. We come in all shapes and sizes. And so, but some people, that's how they judge themselves. That's how they gain their own self-concepts and see themselves is an image, but it's an image that's distorted. In the case study, you have a 15-year-old admitted to the unit with anorexia. You've done a complete assessment. So what would be some important psychosocial areas to assess? First of all, how do they perceive the problem? Looking at their eating habits. Do they have a history of dieting? What type of diets have they tried? What methods have they used to control their weight? Are they restricting their diet? Are they purging? Are they over-exercising? Then you also want to think the value attached to a specific shape and weight. What is their interpersonal and social functioning? And then their mental status and any kind of physiological parameters that might be in place. With the interventions with anorexia, a patient can become severely underweight. So they're going to have that low blood pressure, they're going to have a low pulse and low temperature, they're going to have signs of dehydration, that low serum potassium, and they'll probably be having some dysrhythmias. Anorexia can be treated inpatient or outpatient, which is to help them to maintain their healthy body weight. Their eating produces high anxiety for them, and their anxiety levels need to be lowered if the patient is ever going to be successful in attaining some type of therapeutic goal. So they try to make it pleasurable areas for them to go eat. If they're admitted into a hospital in a crisis state, the initial focus, of course, is to get them stable. Also, we want to know if they have any type of suicidal thoughts. We definitely need to address those as well. We also want to establish some trust and monitor their eating pattern. Based on their height, A treatment goal is set at usually around 90% of their ideal body weight, or of the ideal body weight. And this is where, this is actually the weight in which, for women, that they will menstruate. We usually see anorexia more in women than we do in men. Again, patients begin to refeed, and then they participate in Maloof therapy. They need to make sure that they're feeling, we need to make sure that they're feeling accepted and safe, and no one's judging them by the amount of food they're putting in their mouth. We want to focus on their eating behavior and any anxieties that they feel, dysphoria, do they have, lack of control, low self-esteem. Discuss their appearance. But we have to be very careful to approach that very carefully. When you have your patients with this, lots of times we think, oh, well, just give them a medication. Well, there are no drugs that are approved for anorexia. Now, they do sometimes will give them an SSRI, such as a Prozac type of drug, once they've reached their maintenance weight. And so this can, help them to not be so anxious. Unconventional antipsychotics can be given, such as Zyprexa, and this can help to improve their mood and decrease those obsessive behaviors and that resistance, where they're wanting to resist gaining any weight. However, it's not very acceptable among patients, because one of the major side effects of this is weight gain. So, that is definitely an issue for them as soon as you tell them some of the side effects that they may see. With these patients, they will go through their individualized therapy, but they also attend group therapy with other clients who have the same condition, and they should keep up the group therapies once they are discharged or in outpatient treatment. The other is also families, because a lot of times the families feel powerless, and they feel responsible, or they should have caught something. So it's important to include everyone in the therapy as well. So again, individual, group, and family therapy have been actually very helpful with these patients. If you have a patient with bulimia nervosa, on the assessment, some things we want to do, again, our priority, of course, is medical stabilization, because we worry about, with all the purging, their electrolytes, their fluid balance, and cardiac function. So they need a complete medical exam as soon as they come in, and to run these tests to make sure that they're not at risk. On the assessment, usually they don't appear physically or emotionally ill until you look. They often look really close to their body weight that they should be. Physical emotional problems are usually the most apparent. One of the things that you'll see is an enlarged parotid gland, and this is usually from the induced vomiting. The other thing is a lot of dental issues, such as cavities and like gum erosion from the acid from the purging. Some of them will be rotted out. Some of the teeth will be missing. In box 18.5, they actually talk about some of the medical complications that are involved with the bulimia nervosa. In their history, they may even have some impulsive or compulsive behaviors. Lots of times, what we're seeing with these individuals is there's some family chaos in the relationships, and so they feel like they maybe not a lot of nurturing growing up, and so a lot of instability and difficulties in their lives and their lifestyles. They may even be depressed, have a poor concept of themselves, maybe even have some type of chemical dependency, anxieties, and so forth. We do see these individuals using laxatives and diuretics along with the purging as well. Diagnoses are usually things such as the decreased cardiac output, because of the purging and the potassium level being thrown off. We'll also see the disturbed body image, ineffective coping, powerlessness, chronic low self-esteem, and social isolation. If they do come in poor health because of the purging and the electrolyte imbalance, again, when they're in acute care, it's necessary that we look for those life-threatening complications. And some of those could actually even be gastric rupturing from the binging and purging, and again, that electrolyte imbalance and those cardiac arrhythmia or dysrhythmias. In the planning portion, again, we want to, treat any life-threatening problems, and also any ideas of suicidal ideations. I definitely want to address those. There's a table 18.4 that talks about some of the outcomes that you may want to identify for these individuals as well. And with these patients, with our interventions, we want to aim to interrupt that binge purge cycle. And they may even use psychotherapy and self-care as part of the treatment plan. And then in the end, our long-term treatment is to address any coexisting depression, substance abuse, personality disorders that may be causing this distress and interfering with their quality of life. Two issues that are useful for the patient to target is their self-worth and interpersonal functioning. Again, we look at cognitive and behavioral models of treatment, and they have been found to be very effective. And so, again, examining the underlying conflicts and body dissatisfaction. We also see the comorbidities, again, as such as depression and substance abuse. Any pharmacological interventions, antidepressant medications, along with the cognitive behavioral therapy, actually has helped some of these symptoms of bulimia. Prozac can help reduce the chances of a relapse. And then Wellbutrin can be effective, but there is an induced or increased risk of seizures. So they don't recommend this, especially for people who purge, because of the choking risk that can be come along with this. In health teaching, patients need to be supervised at meals at homes and share their feelings that are provoked by others in group therapies. So we need to be able to know that when they go and they eat a meal, that they're going to keep that meal down. And so they need to be supervised. Part of the teamwork and safety issues, of course, is that structured milieu environment, and observing them during and after their meals to prevent them from purging. We want to normalize their eating patterns and make sure they maintain just an appropriate amount of exercise and not overdoing it. Binge eating is kind of difficult sometimes to understand if someone has this disorder or not, because there is obesity, and obesity does put people at risk for different health issues, which we're very familiar with. And so it's people with binge eating do not need to be put in the hospital or be hospitalized unless they do have an issue that has actually come about because of the binge eating. So patients also who have this binge eating, because they are inhaling these large quantities of food, have gastrointestinal dilation. They'll have difficulties with heartburn, dysphagia, bloating, abdominal pain. They may have diarrhea, constipation, and even anal blockage due to this. On the general assessment, they'll even have periods when their eating feels out of their control. They have no control over it, and they just can't get enough, and they consume a massive amount of food. The major challenge is, to have an understanding about these individuals and realize that they're not just obese and just eating. They can't help it. We also want to make sure that we get a careful history about the quantity of food that they consume in these binging episodes and how often they occur. And this is how we can actually adjust our nursing care plan towards these individuals. Again, they do need a physical examination and blood work. We also want to try to figure out what are some of the triggers for the binge eating and any other medical conditions that might be happening. On the diagnosis, we're going to look at imbalanced nutrition, more than body requirements, disturbed body image, ineffective coping, anxiety, chronic low self-esteem, powerlessness, and isolation. Let's see. Also, outcomes identifications. Again, they have this purple box down below on page 357 that talk about some of the outcomes that are that we want to reach, depending on the symptoms and the diagnosis. So you can look at those. I won't read those to you. As far as planning, we want them to have a usual diet and exercise to allow them for some, for some weight loss. One major difference, though, with the binge eating is the complication of it when it arises when they've, have this mode and they go into this large volume of food that they take in. So it can be a little difficulty when that happens, because then as they're trying to lose weight, all of a sudden the stomach is just completely dilated and the whole and then they start to have all the gastrointestinal problems again. When it comes to acute care, hospitalization is not actually needed. Treatment is usually in an outpatient setting. So cognitive behavioral therapy is a really good treatment that's been used to reduce the number and the severity of the binge eating. Effective treatment for obese patients is binge abstinence. That's what we want them to do, just to not have these episodes, improving their depressive symptoms, and then hopefully helping them to achieve some type of appropriate weight. Because of their efficacy with bulimia and use of SSRIs at or near the high end of a dosage range, it's been studied that this can help them in the short term with binge eating. They do have some other medications that they're looking at and trying to understand how well they work. There is a medication called lorcaserin, and it helps people to feel full after eating smaller meals. And what it does, it blocks appetite signals that can actually go to the brain. And so they are trying this. It actually activates the serotonin receptor in the brain. And so they're trying this in combination with exercise in a reduced diet. And they are getting some success. In health teaching and promotion, they're struggling on how to use food to not regulate their mood and learn how they can use other coping strategies. Once they've had abstinence with the binge eating, they may focus to start changing their body weight by slow and steady weight loss that can actually help them and help them to maintain it and keep it off. I'm not going to really go over the feeding and elimination disorders because we're not really seeing a lot of that right now. So I'm going to just bypass that. I know I have this slide up, but again, it mainly is knowing the definitions of your pica, your rumination disorders, so you have an idea what they are and are familiar with those terms. And with enuresis and encopresis, again, looking at the elimination disorder as well. Just really knowing the definitions is all I'm asking you to do on that. All right, I'm going to let you look at this question and your other questions, and then we'll get back together in class. Here's your next. And the last question.